for offering this incredible opportunity for our Wayne State University students. My name is Jessica Bada, and I am the Vice President of Club Med Virtual. I will be leading today's session, reading any comments posted in the chat, and facilitating the conversation as we go. Before we start, I want to remind everyone to maintain proper etiquette and please keep themselves on mute unless Dr. Kanyinda specifies otherwise. If you have any questions, please post them in the chat and we will address them as we proceed through the session. A Google survey will be administered for Wayne State University students at the very end of the session to verify your attendance, and will close 30 minutes after the session terminates. Please stay on the call for at least 5 minutes after the session is over to ensure that the survey is working for you. This session will also be posted on YouTube in case you're unable to attend or want to revisit certain topics that Dr. Kanyinda discusses today, but you can't receive attendance hours if you're not present in the call and complete the survey. Whenever you're ready, Doctor.
All right, so nice to meet you guys. I like doing stuff like this because a lot of people don't know about oculoplastic surgery, and I'm actually an ophthalmologist. I did my residency at Howard University Hospital. I went to medical school at the University of New Mexico, and then I also did my internship in general medicine in Hawaii, and so now I'm doing a year of oculoplastic surgery. As far as a fellowship, traditionally oculoplastic surgery is 2 years, but there are some programs that are a year. These are becoming less and less as more programs are just transitioning to the 2-year system. And so I want to kind of get into a case here that's interesting, a case I published, and me and a group of people saw a unique opportunity, and we were able to get this case in one of a pretty nice journal in ophthalmology. So let me see if I could share my screen here. And before I get into the case itself, I actually do want to talk about, just in general, some common things that I do see in as far as oculoplastic surgery. So ophthalmology has different specialties. So that includes glaucoma, retina surgery, which is surgery in the back of the eye. Glaucoma, obviously, patients have high pressures, it can damage optic nerves. So the surgeons put shunts in the eye to help reduce the pressure. There's also neuro-ophthalmology, which is a combination of neurology and ophthalmology. There's also uveitis, which is, a good combination of rheumatology and ophthalmology, and dealing with autoimmune conditions and inflammatory conditions that affect the eye. And of course, there's cornea. They do transplants. They do different types of surgeries as well. There are a couple other specialties, but in general, ophthalmology is a pretty great field. The work-life balance is awesome. We do have emergencies though, but a lot of these emergencies can be pushed like the next day or at another time. And so before kind of getting into the next case I was going to talk about, some common things that we see in oculoplastic surgery. So here you see, this is a picture of an orbital floor fracture. You could see that there is, the muscle is sort of stuck and outside of the fracture. And this is something that we call muscle impingement. And sometimes I'm called to see this. This is something that we could potentially take, or we would take to the OR, and we would do an orbital floor fracture repair. This is another example of a guy who had a blowout fracture, and again, fractures, we either do surgery on them or we don't, and sometimes they get effects later, like double vision. They get sometimes situations where their eye is sunken in, and so we try to do surgeries to correct those types of things. We also, as oculoplastic surgeons and general ophthalmologists as well, see a lot of lacerations. There are lacerations that can involve the tear duct system, and those require special types of repair. Dog bites and all those things. This is a basal cell cancer. In oculoplastics, we work really closely with dermatology, and we do after they get Mohs reconstruction or Mohs surgery, we sometimes do the Mohs reconstruction, and we help kind of put back together things that have been either cut out, or if a tumor is very invasive, we have to figure out how to be creative and put it back together again. This is a person with thyroid disease. You may have seen pictures on TV or in the news of people with their eyes bulging out, and the people will have memes and stuff like that. And I always tell people, don't be careful making fun of people, because sometimes they actually have a real condition. This is a thyroid disease. You can see that their eyelids are they have upper lid retraction. There's a lot of their white part of the eye, the sclera, that's showing. And patients like this, when they're having really severe thyroid disease, we have to take them. Sometimes we have to take them to the OR for various issues that they may have. There's a lot of different surgeries that we can do to help these patients, and obviously medications. This is a person that has a blockage of their tear duct system that's created an infection called dacrocystitis. As we do surgeries, sometimes when people have recurrent, or sometimes they have even a single episode, we go in there and we create a new passageway, and we put a tube and a shunt through from the lacrimal sac to through the nose, and so that we can create a clearer passageway. And sometimes we're drilling through bone, trying to get there, and it's a cool surgery to do, because it's like you're in the nose, but you're also connecting the eye and the nose. And so you end up putting a tube through, and you pull a tube out of the nose, and it stays in for several months, and then they're just healing around that, and that helps kind of create a new passageway. But generally, we initially treat this with antibiotics, and it definitely is responsive to that. Here you could see a person with eyelid droop. You can see one side of their face is droopy, and or their eye is drooping, and the other side is not. We do a lot of eyelid surgery, so sometimes people can't close their eyes. We can put in a gold weight to help their eyelid fall from the weight. Sometimes people have droopy eyelids, and we have to decide what the reason for the droopiness is, and we can go in there and we can do different types of surgery to kind of get the eyelid droop corrected. This is a picture I threw in here. We just did a case. This isn't my patient, but my patient looked like this. We essentially took mucosa. It's a person that had something called Stevens-Johnson syndrome. It's kind of a syndrome that affects the skin and mucosal tissue, and sometimes it's a side effect of certain drugs, certain medications. And so this person actually had irritation of their eye because of the damage from this condition. And so we actually, just like in the picture you see, we took out a piece of mucosa from the mouth, and then we placed it on the eyelid, and we glued it, sewed it in, and we actually saw this person today, and they're healing very well, and they have just this beautiful new healed area that's not going to be irritating for them. And so we do a lot of cool things. Additionally, sometimes we even take fat from the belly, and people who have what we call enophthalmia, where we took the eye out and we need to kind of help their volume, we can take fat from the belly and kind of put that into the eye socket, and that will kind of help those people reform so that they can get a nice prosthetic and look great again. Sometimes people think that when they lose their eye, it's the end of the world, and it's a very traumatic thing when somebody's in an accident or they have to lose their eye. But we have amazing technology where we can give people prosthetics, and we can give people different things that can help them sort of live a normal life again. But this is just to show that we do work in the eyes and around the face, but in oculoplastics we also delve into other things where we kind of combine and use our medical knowledge to sort of help put people back together again. This is a case. This is me and my fellowship director. We're doing a case. We're using a special image guidance thing called the Stealth. And so essentially what we're doing is, this is a person who had a brain tumor that affected their eye, and it's called a meningioma. And so the brain tumor essentially can create changes. It's called a sphenoid wing meningioma. It can create changes in bone that can make bone thicker. So this person had their bone was so thick that it was starting to press on one of the eye muscles, the lateral rectus. So what we did is, in the orbit, and so what we did is we used the image while we were operating, and we had a probe that showed us exactly where we were at each moment, at each second of the operation, and we were able to drill and shave off the extra chunk of bone that was in response to this meningioma. And so you can see the technology is awesome. The stuff that we're doing is really cool. It's great. And we're just kind of doing a lot of high tech stuff. You can see, I kind of have to bend a little bit. I'm 6'4", so my neck. I hope my neck survives, in the next few years. But you can see that we have our headlights. We're kind of in a deep space, in a deep orbit there, and so that's kind of essentially there's so much more to oculoplastics. But that's just kind of give you guys an idea that we do a lot of stuff. It's a good combination between ENT, dermatology, and maxillofacial. We do a lot of those types of things. And so again, so I'm an oculoplastic surgery fellow. I'm also a faculty of the School of Medicine, and at the University of Mexico, I'm also a staff ophthalmologist at the VA Medical Center, where I still do like at least one day a week. I do some cataract surgery over there just to keep up my cataract surgery skills. And so today I want to talk to you guys about a patient that a published paper that we did about a patient that presented with a very rare orbital tumor. Again, I have no financial disclosures. It would be nice to have some, but right now at this stage of in the game, I don't have any. And this is a 28-year-old African American male who didn't have any other medical history. He came to the emergency department because he was having a progressively growing right eyelid mass. And this had been growing over the course of 4 months. And interestingly, he had been putting this patch on his eye because he thought it started off as a small thing. And he had been managed for, some of you guys may know what a sty is, or a bump on the eyelid called a chalazion. Initially, that's what he was managed by his primary care doctor, optometrist. They managed him for when it was a small little thing and people thought that it was a sty. They thought it was a bump. But all the while, it was this growing mass that was a potential tumor, right? And so essentially they tried all these different things and there was no resolution. Something happened where he bumped the mass, and the mass actually elicited bleeding from it. And he also had some nasal discharge that was bloody. And so this, you could imagine if you have this kind of little bump on the eyelid that's growing, your nose is bleeding. You would think it would take less than 4 months, to come to see the doctor, right? He had seen some other people, but he was trying to cover this up with a patch, and that's something that's also important to understand with patients. Is patients don't know. Sometimes they think they can brush things off, especially male patients. Today's International Men's Day. Happy International Men's Day to everyone. But one of the things with men that I always tell people is men are 3 times less likely to go see a physician. And so this is a young guy. He's been healthy all his life, and he's probably not thinking that it's something serious, right? But as we're going to see the story unfold, it's more than just a bump. That probably would have been a cooler story title for this, but oh well. And so essentially, the patient wasn't on any medications, and his past eye history was negative. He did have a history of smoking and tobacco abuse. And whenever you think about cancer, whenever you think about that type of picture, you always want to think about, is that person smoking? Are they drinking alcohol? Do they have a family history? And so when you see me say this person had no pertinent family history, it's me saying that I'm kind of on the lookout for what could potentially be going on. Also, his physical exam, his actual general exam, it was normal. His eye exam, you'll see. We'll talk about it in a second. The labs that were obtained showed just a mild white count. The white blood cell count usually raises when there's infection or there's inflammation in the body. So you can have an infection that raises the white count, but other things that can raise the white count are also inflammatory things like autoimmune conditions or tumors. These are things that can raise the white count. Now, sometimes if the white count is mildly elevated, we don't always chase that, right? We have to compare with the symptoms and what the patient is going through. So this patient had a mild white count, and that's what leukocytosis means. And his HIV test was negative. I mentioned HIV because HIV is very paramount in regards to presenting with really weird things, really weird diseases, very weird tumors. And you have to ask people about sexual history. People come to the eye clinic and they always get upset and they say, well, Dr. Nate, why are you asking us about our sexual history when we just came, we came for you to look at our eyes. Why are you asking about sexual history? Well, I can't tell you how many times I've diagnosed HIV, I've diagnosed syphilis, I've diagnosed chlamydia, I've diagnosed gonorrhea, I've diagnosed the most random things just by looking at your eye one time. And I've seen the eye and I say, okay, this is, there's more to the story. But in his case, even though he's a young guy, HIV testing was negative. And when we look at the vision, whenever you look at a person's vision, you always want to say, when the ER calls me, sometimes I'm on call, and the ER will call me and say, hey, there's a patient that we want you to see. And I'm like, great, awesome, tell me about the patient. And they've never checked the vision. And it's like, if you're going to call an eye doctor, if you're going to call an eye surgeon, please, you future doctors, future ER doctors, family doctors, nurses, whoever, check the vision, right? You don't have to be a mastermind, but if you check the vision, if you can at least say they can see light, they can see my fingers, they can see, that's very important, and it helps kind of paint a picture in the story. So the patient had 20/40 vision in the right eye and 20/20 vision in the left eye, which means that essentially his vision in the right eye was slightly decreased, right? And that could be because of what's going on. It could be because maybe the eye is has some kind of refractive error, or he needs glasses or whatever. But in the context of the affected the affected eye, you have to think about, that's suspicious, right? He's coming with symptoms on one side and his vision on that side is decreased. I looked at the pupils. Pupils were normal. Pupils are a good way to assess optic nerve function. His eye movement, kind of following his eyes and seeing how he does with different gaze directions and movement, that was normal. And his eye pressure, his intraocular pressure, was also found to be normal in each eye. So on the exam, the eye exam, I did, the initial exam for the anterior part. There was just in the right eye a large medial nodular mass, and then I also looked in the back of the eye. And the back of the eye was normal. There was nothing going on back there. And so this is what he looked like. So when he presented, you can see this large nodular mass. It's towards the nose. So in this case, we would say it's medial. It's integrated. It's a lot of. It's not like a clear cut, well circumscribed mass, right? It's just very there's different colors to it. It has it's kind of complicated, right? So when you see something like this, call me. It's okay to call. I'll wake up in the middle of the night. Call me, even if I'm not going to deal with it in the middle of the night. This is a very interesting case, and this is a very serious thing, and it's a very rare presentation, right? And a guy that's 28 years old and that's African American, which at this point there was no literature showing anyone this young and anyone of the African American race that had this particular condition, which we'll talk about in a second here. So we did some imaging. Whenever you see something like that, you always want to get a scan. It was a large soft tissue mass that was in the anterior medial orbit, and it essentially displaced. There was some displacement of the actual eye itself from the mass. And so let me actually show you this mass here on the scan, and you can see on the scan that the mass is right there. You can see the sinuses there. And you can see the medial, and I have some arrows pointing, and the eyeball is you can see kind of the eyeball on the other side, right? And compared to the eyeball on the right side, you can see that he has this large mass, right? That's literally pushing. It's even pushing the eye a little bit, right? If you look closely, and so that's very concerning. I don't know if you guys are scared yet. I'm scared at this point. In an educated way, I'm like, we gotta look into this. We got to look further into this. And so you can see that this scan tells us, and it shows us a lot. We did do debulking of the mass, and we got pieces of it. We're able to send it for pathology. And the pathology, this is why doctors who are pathologists are so important, right? Because they can sit there and they can tell you what something is, right? So when you're diagnosing somebody with something, you don't know what it is, it's the pathologist who makes that final call. And that's why their job is so important. But for those of you guys who remember biology and remember some things from cells and all that, Here we have atypical squamous epithelial cells. And that key word is atypical. They're not normal. And then we see mitotic figures, which also is a sign that these cells are proliferating. Right? I don't know if you guys remember mitosis, but mitosis just means the cell is growing, right? So these cells are proliferating, and these are atypical cells that are growing, right? And they're infiltrating the normal tissue, and that's kind of the biggest take home to understand here. This is another pathology slide here showing that there is transformation of squamous cells lining the periphery, and they're becoming atypical neoplastic cells. And these may be buzzwords you guys remember as well, like increased nuclear to cytoplasmic ratio, pleomorphism. These cells are not the normal cells that you would see. And so now we're in the range where we saw the guy, we saw the scan, we saw the pathology. We're pretty sure now that this is a squamous cell carcinoma of the lacrimal sac. The tumor was staged. TNM staging tells you about, like a tumor size, tells you about node, like lymph node involvement, and metastasis, right? So from what I remember and recall, that's tumor staging is something oncologists and people who deal with a lot of tumors use to figure out how serious a tumor was. So meaning that his tumor was local, not necessarily in the nodes yet, and not metastasized yet. And so initially, back in the day, there was this kind of push to just do surgery on these patients right away. But we had a tumor board meeting, we had oncologists, we had us, we had different surgeons, and we decided, we're going to do this thing and do pursue chemotherapy and radiation instead. So the patient received, actually 3 cycles of cisplatin with a radiation regimen, and the tumor completely resolved after 4 months. And so we could say, hey, we cured cancer. Let's celebrate. Let's go get some beverages at the local, whatever. I don't know if you guys like dive bars or whatever, but let's have a good time. But no, we can't stop there, right? Because now this is where medicine can kind of get complicated. We have to understand that while you're treating something and you're treating one thing, you're going to potentially have side effects from that treatment. So although the tumor went away, now we have new problems because of the radiation, right? And it's important when you do radiation, especially on an organ like the eye, the most important thing is being able to shield the eye. And even with proper shielding, the eye can still go through complications. And so later on, as he comes back, fast forward multiple visits, multiple follow-ups, and finally we fast forward, and he finally has this severe eye pain, hand motion vision, which means he can only see your hand moving, and he has this large epithelial defect, and he even has cicatricial membrane formation, which means he has kind of this abnormal membrane in the mucous portion of his eye, in the inferior fornix. And so he's not doing well, right? Like the tumor's gone, but now his eye hurts. He can't see. And over months, he continues to have these symptoms, and then his vision gets worse, right? So if you can't see hands anymore, what's the next step? You can only see light. And unfortunately, the worst step after that is you can't see light at all, complete blackness. And we call that NLP, or no light perception. He was at the light perception stage. And so we took comfort care measures, and we performed what is known as an enucleation. Enucleation means that we take out the entire eyeball, and we fill it with a prosthesis, and we take out the eye, because it's, we do that for the main indication is a blind, painful eye, right? When if they're blind, it's just hurting, their pressure's high, they're having tons of complications, it's ruining their quality of life. We have to do what's known as an enucleation. But since then, he has remained in remission, and that's kind of the most important take home, right? Is unfortunately he did lose his eye, but on the bigger spectrum of things, he's not going to die of cancer, right? And so we saved his life, and sometimes in the process of saving a life, some things take an L, right? Some things are going to happen. You're going to have some side effects, and so my talk kind of goes into the anatomy of what's going on, and I'm not gonna touch base off everything because for the level of this talk, it's kind of a little bit more complicated, and this is kind of geared towards ophthalmology residents. But just to kind of give you an idea of the anatomy of where that lacrimal sac, some of you guys may have been listening and been like, what is that? Where is that tumor arising? Well, if you look at this picture, you can see that we have the lacrimal gland, right? Lacrimal gland is important for producing for tears, for producing tears, especially when somebody's crying. People are crying a lot. Sometimes it's funny because the lacrimal gland, when it's abnormal or when there's a cyst, you'll have patients that say, I feel a bump here that gets bigger when I cry. And when you hear that, you got to think about lacrimal gland, right? And so you see the tear drainage system, and then you see how it goes from the punctum and the little kind of holes that you might see kind of on the eyelids, and it drains through there to the canaliculus, and then there's a whole lacrimal sac, and it connects to the nose, and that's why sometimes when you cry, you sniffle because it's going through your nose. So there's a connection between the eyes and the nose, and that's the biggest thing to understand. And so he had a tumor of the cells that line part of the system, and that's where that tumor was literally growing out of to the outside, and that's what you could see when you saw that picture for him. And this is just another picture showing that. And I talk about here just how it could present, and how in the past they never used chemotherapy, or they usually use surgery first, but how chemo and radiotherapy has become more popular in the last few years. The most important take home before I'm done kind of with the presentation is to understand that, in our case, this is the first African American in all of literature, right? It's 2020, and this is the first African American identified in literature to have, and youngest patient reported to have, squamous cell carcinoma of the lacrimal duct system. And he presented with a large mass. He showed quick resolution of his tumor, and despite non-surgical treatment, he was able to remain in remission. We didn't have to go in and do a complete, and because it was localized, we didn't have to do an exenteration, which is different than enucleation, where we just take out the eyeball. In the exenteration, we take out everything, the entire orbit. And we clean everything out, and we'll do that with like tumors that spread. But because he had such local involvement, we just decided to just do an enucleation. And so again, this paper was published in the American Journal of Ophthalmology. Special thanks to Dr. Soni, Dr. Ramadan, Dr. Kidwell, who were all a part of this work. Here are my citations, and of course, here in the middle is Dr. Kidwell. He's actually I don't know if he was the first or one of the first Black oculoplastic surgeons. He may have been the first Black oculoplastic surgeons in the U.S. He trained at Hopkins. He trained at Bascom Palmer, both top institutions for ophthalmology. That's me over there, kind of standing, trying to look cool, but I wasn't as cool then, I promise. And that's Dr. Angadi. He's a general ophthalmologist, and we had just gotten done doing a plastics case over there at Howard University. And so, and that's it for the presentation and what I have for now. But I guess we could open up for questions if you guys are ready.
If you guys have any questions, you can either type it in the chat or just unmute yourselves. Okay, there was a question. Did you always know this was the field you wanted to go into?
Yeah, so that's a good question. I actually did not know that this was the specialty that I wanted to do. I had an idea that I wanted to do ophthalmology. I used to do a lot of medical missions when I was in med school. I went to Dominican Republic. I went to Kenya, to do neonatal research. And, I just sort of just fell in love with medicine in general. And ophthalmology, I actually watched a documentary about some ophthalmologists who were traveling all over the world and they were doing cataract surgery. And the crazy thing about ophthalmology is when you do surgery in ophthalmology, you see the results pretty quickly. If somebody's blind and they can't see their family, they can't see their world, they can't drive, they can't go to work, and you just take out their cataract, and all of a sudden they can see the world, they can see color, they can see light. That's a really monumental moment in someone's life. And so for me, I was inspired by that. Surprisingly, actually, through med school and through the end of med school and even interviews, I actually was interested in interventional radiology for most of my med school experience. And so I actually thought I was going to be doing radiology. And I even interviewed at some radiology programs and some interventional radiology programs. But I sort of felt like, I had a friend of mine, a really close friend of mine that knew me and said, "Hey, I think that ophthalmology might be the route for you. It might be something that you would be really good at, and you've talked about it." And I switched last minute, and I went into ophthalmology, and it's been great. It's been quite the adventure.
Awesome. Someone asked, what was your undergraduate career like, and were you a traditional applicant?
Yeah, so my undergraduate, I actually wasn't. I wasn't always. I didn't know that I was going to do, medicine. Right. A lot of people, a lot of my colleagues and some other doctors will say that ever since they were 8 or 7 years old, they wanted to be, they wanted to be a doctor. For me, I wasn't thinking about becoming a doctor. I was playing Super Nintendo and 64. I wasn't thinking about that kind of stuff until when I got to college. I was actually starting off playing. I got a college basketball scholarship, and for the first 1 or 2 years, I was trying to figure out if I still wanted to play basketball, if I still wanted to do athletics, and I decided not to go that route. And I actually, my junior year, I decided to go into medicine, and I kind of did like a trial version. I told myself, okay, I'm gonna take chemistry, and if I do well in chemistry, it's kind of dumb to do it like this, but if I do well in chemistry, then shoot, I'm just gonna keep taking these classes and see how I do, and if I like getting A's, and maybe I can become a doctor. But things just worked out. They worked out, and so I actually ended up doing college in 5 years because I decided I wanted to do medicine later, and then I took time off. I took a couple of years off between medical school and undergrad. And what I did in that year is I took my MCAT, the first part of it, and then the second part of it, I actually was a teacher and a tutor at a community college. I taught biochemistry and chemistry and everything that everybody hates. I taught. So, but I enjoyed it. I like science, and so it was a great job because I was able to make some money and I was able to travel the world. So I used that time to backpack Central America, to live in Brazil. I just told myself, hey, I may have a wifey and some kids one day, and like I might be busy one day with private practice. Maybe this might be a good time to enjoy my life. And so that's kind of like what I pursued, and that's kind of what I did. So in some ways, I didn't go straight through. I took 5 years instead of four, and then I took 2 years off in between. And looking back, to be honest, I'm glad I did. Because you only live once, and you're in your early 20s once, right? So you have to remember that as you're pursuing medicine, you kind of have to go at your own pace. So if it means taking a research year, if it means doing an extra year so that you can make your application better, don't focus on the time, because the time will come and you'll work for 20, 30, 40 years, right? So there's no rush to get to something that is a long-term process.
Mhm. Backtracking to the case study, someone asked, was there a reason why the patient took so long to come in?
Yeah, that's a good question. Unfortunately, patients, they don't. It's so important as a physician, as a doctor, or future doctors, that you understand that your patients have backgrounds and they have environments and social circumstances that are sometimes very different than our own. Right? Some of us we come from different backgrounds and different places, but we at least have the opportunity to kind of be exposed to some things and be educated about some things. And especially as doctors, we're so highly educated, we have to sometimes step back and realize not everybody is going to, that light bulb isn't always going to turn on. Sometimes I think in this case, the patient was scared. I think, some people, they see something and they're right away, they go to the doctor. Other people, they see something and then they're scared. They're worried. What if I go in and they tell me it's a cancer? But the problem with that is if you wait too long, you're something that could easily be treated in the beginning. Maybe in the beginning, we could have just taken it out, right? We could have done a dacryocystorynotomy and just taken something out. But unfortunately, he presented too far and too late into the game. And so I think that, I think he comes from, this was a patient that came from a pretty tough background, and a patient that came from in an environment where, a lot of those patients don't always come to the doctor right away.
Okay, someone asked what prevented you from doing surgery on the tumor, and then if the tumor was removed surgically, wouldn't it have had less side effects for the patient compared to chemotherapy and radiation?
Yeah, that's a good question. I think that whenever you talk about surgery on a tumor, there's a couple things you have to think about. Um, you have to think about surgery is a pretty invasive thing, right? It's a pretty invasive process. When you're operating in a location like that, in a place like that, if we had operated on that, we definitely would have for sure changed, a lot of the kind of the anatomy and the structure and the function of his eye just by going in there and essentially just cleaning it all out. Um, the hope, though, with the radiation is that you can potentially do radiation, and if there are no complications, perhaps he can, still kind of keep his visual function, right? But the reason why this is a good case report is because it's kind of it's a good lesson to see that there's no perfect clean cut route, right? We could have done surgery, and if we had done surgery and just taken everything out, that would have been a pretty big traumatic thing. We've taken it all out, but he may not see again, right? Or he may not have an eye, or he may not, right? Depending on, because you saw how far that tumor went, it was pretty deep in there, and so to get that, you have to do some pretty big moves to get that tumor. And so if you could save it without surgery, and the patient can still see, it's a big win, right? Because it's a big tumor, it's a big mass. But unfortunately, he did have complications from the radiation, and so I think that in the end, it's still kind of a win because whenever you take out a tumor, a cancer that could potentially spread to other parts of the body, I think that's unfortunately I feel like that takes more of a priority than just a person's vision, and I say that as an eye doctor. I think vision is so important, but I think life, just being able to have your life, is also very important.
Someone asked if the patient came earlier, will he have a chance to not lose his eye?
Yeah, I mean, I think with cancer, with tumors, the name of the game is sort of early detection, right? That's why even with cervical cancer, they always do pap smears or they do the HPV test. They do things to sort of try to prevent and to screen and to help people, right? To kind of that's why they do colon cancer screening, right? We heard about Chadwick Boseman, who was diagnosed at 39, I believe, with colon cancer. But it's so important to understand that the name of the game with any tumor, any mass, is early detection. If that mass, because it was in the lacrimal duct system, it's a little harder to kind of find right away. But when it was kind of in the early beginning and people were treating it like a chalazion, or they were treating it like a sty, that would have been the time where, yeah, for sure, he would have been able to kind of had a surgery where we could have preserved his eye much at a much in a much easier way.
Someone else asked any ideas on why the patient's condition was unilateral? Any ideas on possibly a previous infection that could have caused the cellular proliferation?
Yeah, so I actually have a theory on this after when we wrote the paper, when I kind of studied and read a few things. Um, Squamous cell carcinoma is so first of all, cancer is random proliferation of cells, right? So it doesn't choose to be bilateral. I mean, it's one of those things where cancer just does what cancer does. Tumors do what, when they're abnormal, it could just grow on one side of your face and this or that. Bilaterality is not necessarily something that we pay too close attention to, for the most part with most cancers, right? Um, but as far as the type of cancer, he had a squamous cell cancer. And if you remember, squamous cells line a lot of areas, right? We have squamous cells in our mouth, right? I just mentioned cervical cancer, right? There are squamous cells there, right? And so that's why you remember in the history, I mentioned smoking. People who smoke, right, they can develop squamous cell cancers, right? Oral cancers, cervical cancers, certain types of lung cancers. And so it's so important to understand that a patient's history, they're smoking and potentially infectious, right? We weren't able to see if he had been exposed to HPV, but it's my suspicion, I highly suspect that he may have had HPV because HPV can cause cancers like that. HPV can cause squamous cell cancers like that because it doesn't make sense. He's 28, he's young, he's in an ethnic group that's not common in. He's a smoker, yeah, but he doesn't really have that many risk factors, no family history that we know of. So it kind of pushes us in direction to kind of think about what else could do this, right? And so in my mind, as a doctor, I'm thinking, this could be HPV. HPV can do that kind of stuff, and HPV can affect the eye in general. So that's just my kind of theory and my thoughts on that.
Someone asked if you had any tips specifically for us in our undergrad if we want to pursue a similar route. What can we do now, like during the pandemic, that will potentially benefit us in the future or make it easier for us down the line?
Yeah, I think that's a great question, and you guys are in unique times, because it's the pandemic, and it's really awkward in knowing what you should do and what to do. But we also live in a social media and digital generation where doctors are, if you guys follow me on Instagram, you guys follow me on TikTok or whatever, I talk about my surgeries, I talk about my day, I talk about something, my experience, my journey. And a lot of doctors are doing that now. A lot of surgeons and family doctors and private practice doctors are sharing their journey. And when I was coming up, I didn't have I didn't have like mentors like that. I mean, the only I had a family member that was a physician, and that was it. But I mean, my undergrad people, they told me, oh, being a doctor is hard. Are you sure you want to do it? I remember when I was getting recruited to play basketball, a professor told me, don't even try to do anything like becoming a doctor, becoming a lawyer. All I heard was just, people telling you that it's too hard, that you can't do it. And so the first piece of advice is kind of philosophical. It's like, once you decide that you want to be a doctor, and once you decide that that's what you want to do, don't worry about what anyone else thinks about it. Don't worry about what anyone else has to say about it. People are always going to tell you that something's hard. If it's a class, they're going to tell you, oh shoot, that class was so hard, good luck. They'll always try to give you the negative aspect, but you can become a doctor, you can do it. And I think the advice I would say is sort of, don't spend time looking at these blogs and these different things. Kind of focus on doing as best as you can in your classes. Do as well as you can. And if you feel like your application can be stronger, then take a year, to do like a research thing, or do like a master's program or a post-bac program. But there's no rush. Just get yourself in the best position you can to get into med school and to become a doctor. I believe when I was at Howard doing my residency, I remember hearing numbers. There were thousands of applicants. I don't know if it was like somewhere between to 15,000. I don't know. There were like thousands and thousands of applicants just for 100 spots. So it's really competitive. It's really competitive, and so you have to network. So these doctors are posting. People find a mentor, find somebody who is a physician that can mentor you, that can give you advice, that can tell you, look at your application and tell you your chances, and or tell you if you have to kind of take something more. Because if you don't find a mentor, you're just going to be kind of like navigating yourself, especially during this time right now. I believe that a lot of my friends who are doctors are really open to you guys contacting them and asking them for advice, or contacting them and asking them to help, to kind of help them through what you're doing. And so obviously it's obvious that you should get good grades. It's obvious that you should do good on your MCAT. Those things are obvious. I also think it's important for you to do some kind of volunteer work or something. I know it's COVID, so that's a little different, but maybe you're doing something, that some kind of research or something that kind of helps you stand out from everyone else. And you don't have to do a million different things. Just whatever you do, just be able to talk about it in an interview. Make sure it's something that you're passionate about, and make sure that it's something that reflects who you are. And that's kind of like the biggest thing from the undergrad perspective. I wish that in undergrad, that I would have just not listened to all the people, all the teachers, the professors, everyone that's so quick to tell you that it's too hard, right? Because they're still doing what they're doing, but now I'm a doctor, right? So it's like you have your own journey, and if you don't know what to do, make sure you have a mentor that's there so you can ask them. I'm an Oculoplastic Fellow, and I still have mentors. I have my fellowship director that I reach out to, because just because I'm done with residency and I'm done with my training, there's still so much to learn when you're even a young doctor. So you need to go to people who have been there in the game for a long time, whether it's a med student or it's somebody that's already in med school, or somebody that's in residency, somebody that's in attending. You got to talk to people who are in the game and ask them, what can I do from this point on? And I think that's the biggest piece of advice I would say, is have a mentor.
Someone asked, what are some other ocular issues that require an enucleation?
Yeah, that's a good question. Um, so for example, if you have somebody who comes in with an intraocular tumor, right? In general, with tumors, because they can spread, it's a fine line between doing enucleation and doing exenteration, depending on how extensive the tumor is. I saw a guy the other day who had an eye infection called endophthalmitis, essentially he had a kidney infection that was undertreated. He was from like a small town. The kidney infection was undertreated. It spread to his blood, and then from his blood, it went to his eye, and then created a massive infection that infected the entire eye. He lost his vision, and then he ended up having severe pain, because when the eye stops working, dysfunction, it's not functional. Patients can start developing a lot of pain. And that would be an example of a patient, once the eye kind of calms down, a little bit. That's an example of a patient that we would do an enucleation in, right? Somebody that's lost their eye because of something, and now the eye is now becoming more of a nuisance. They can't see any light, they can't see anything, and so we just remove the eye, and it's more of a comfort care type of measure.
Someone asked if you could show the slide showing the.
Sorry, what was that? I don't think I heard the question. I'm sorry.
Yeah, Jessica, you're cutting off, but they asked to see the slide of the tumor.
Okay, yeah. Let me show that. Let me see if I could share my screen here again. And let me go to, you guys can see my screen, correct?
Yeah.
All right, and so you could see here, the tumor is right there. Yeah, so, and then again, just to kind of refresh you guys' memory, there it was on the scan. And so you could see when I was telling you guys to go in and get this surgically, right? It's going to be a pretty big surgery, right? And so that's why it's never really like a clear decision per se, and you just kind of have to weigh out the patient. You have to ask the patient what they wish too, right? Because it's not just when you're kind of borderline like this, you also want to ask the patient, what are your wishes? What this is how serious your condition is. This is what we would recommend, or these are the things we would recommend. What do you think? What do you feel about this? And I believe that he wasn't a big fan of us doing surgery either if he had the option of radiation. And so that also is a big thing that helped lead our decision making.
Okay, I'm taking over because Jessica's Wi-Fi is not working. Someone asked, what would be your second choice of field if you wouldn't do what you're doing right now?
If I wasn't doing what I'm doing, I think that if I wasn't doing ophthalmology, which is awesome, by the way, I think I probably would have done, I probably would have just exactly what I was choosing in med school, interventional radiology. I think interventional radiology has some similarities, so now I showed you guys some pictures where I look at scans a lot, I look at imaging a lot, I base a lot of, in our team, we base a lot of our decisions based off of scans and imaging. And you saw us doing couple cases there in the slides where we use imaging to guide us. And so I think, ophthalmology and radiology for me shared similarities in the sense that they're both fields where the diagnosis is heavily dependent on what you see, right? So if somebody comes with, for example, something as simple as a red eye, right, you see the red eye, right? And so you can just look at them, and if you just know a little bit more information, you can diagnose that, right? Same thing with the tumor you saw, right? We saw the tumor, you can see that, and we do a lot of imaging, and we do a lot of scans in ophthalmology, and a lot of our decision making in ophthalmology, especially like retina and some specialties like that, we use a lot of imaging, even glaucoma, looking at the nerve, doing visual fields. We use a lot of our knowledge based off of objective data and that kind of medicine, and radiology does that too. And so for me, I just like the idea of being able to look at images, and I like the idea of being able to do procedures, and I like the idea that there aren't a ton of emergencies compared to other surgical subspecialties, and the lifestyle is pretty good. I have a great, you have weekends off unless you're on call. I think this weekend, like I'm going on a little road trip. It's like you get a pretty decent lifestyle in ophthalmology, and so that's something that I would say is a big benefit of that. But I would say radiology for sure. I think if I were to go back and ophthalmology wasn't an option.
Someone asked, what programs did you do on your mission trip? I'm sorry, what
Yeah,
programs did you do your mission trips with?
yeah. So when I went to the Dominican Republic, I actually went with this group called Solid Rock International. It was like a Christian based kind of like group where the doctors and med students could volunteer and go. And so we would actually go to like little villages throughout the Dominican Republic. And I think one time we crossed over into Haiti, and we would just go in buses, and there'd just be lines of people just waiting to see somebody, just waiting, and they would have these crazy things going on with them, just like full-blown heart failure right there. And it was really awesome. When you go out there and you go out into the world and you see how much people really need your knowledge and expertise, even as a med student. I didn't feel like I knew anything. I didn't know anything as a med student, but I think that the little bit of knowledge I did have changed people's lives, right? And so that was a great group. I don't know if they're still going, but that was a group that I actually went with, and we did the Dominican Republic. For Kenya, there was actually a family doctor that would go. He would travel to Kenya, and he would do research projects and all of that. So I tag teamed with him and a few other people, and we actually did research in neonatal survival, because the neonatal survival rate, newborns were just dying like crazy there, right? So what we did is we trained people from the community that were interested, and we gave them a little bit of a little bit of money, but to give incentive, and we trained them to look for signs of distress in babies. And just by doing that, we saw the survival rate jump and increase like crazy for these infants. And so we were going down there to help train these workers And then we also opened up a maternity ward. And so the medical trips that I did go through, one was through my med school, and then the other was through kind of an outside organization.
Someone asked, where can we learn more about the information you went over today?
Yeah, so I always tell people I'm kind of like a technology person. I think that I would highly suggest if you're on social media, follow people who doctors who post about their journey or post about their work because back in the day when Instagram came out in 2012, I think before that there wasn't anything where you'd have to literally go in and shadow. But I think right now you can actually get a good idea of fields that maybe you would have never seen before just by even going on YouTube or looking up certain specialties in certain fields. But I think if you'd like more information, I would start sort of with basic things like that because now there's even I go on YouTube to look up some surgeries if there's a surgery that's coming up that I'm doing or that I'll be a part of. I look at YouTube and see how somebody else in New York or something did that surgery and see how I could potentially incorporate some of those things in my surgery. So yeah, so I mean that's where I would start. I would start with kind of online, social media, YouTube, Google, all of that.
Someone said, was ophthalmology a difficult field to get into, and do you happen to know anything about ophthalmology fellowships?
Yeah, so ophthalmology is among the more competitive fields. The average, I think last time I checked, when they were scoring step one, I don't know if they're doing that anymore, but step one is kind of the first part of our licensing exam, and the average step one was somewhere, like it was like 245. So it was like, and so you can imagine the average score for med students is like 230, 229 or something around that, at least the time I was doing it. And so, yes, you have to be pretty good, in med school and pretty good, as far as your grades. But with that said, can you get into ophthalmology and not be top of your class in med school and not have done amazing on your licensing exam or board exams? Sure, yeah. I mean, that's where it comes down to sort of your work ethic and getting to know other ophthalmologists and people like that. All of those fields, dermatology, orthopedic surgery, plastic surgery, all of those are fields where it's not very easy to get in. Ophthalmology fellowships, they vary in regards to competitiveness. Oculoplastics is going to be a little bit more competitive because either there's not a ton of programs out there training oculoplastic surgeons, so it's just competitive just because of that. Retina was traditionally competitive as well, but that's kind of not as much as it was, as more people are doing general ophthalmology as well. And then the other specialties fellowships aren't, they're just kind of normal. They're not anything that are, it's incredibly difficult to get. You can find a fellowship in pretty much anything that you want to do.
Someone said, can I improve my eyes without laser surgery?
That is a big question. So I would say get an eye exam and figure out what's wrong with your eyes. And if it's just like glasses and you need glasses, refractive error, doesn't change, right, just by itself. So either you're doing a laser refractive procedure to change it, you're doing some kind of other refractive surgery. But yeah, I mean, if you just kind of hang around, generally eyes get worse with time, and they don't necessarily improve with age. And so, yeah, I mean, there's not much you could just do to just improve your actual refraction, but you could do little things that can help your vision be clearer. If you have, like, let's say, dry eyes, you can take artificial tears. If you have other things going on, there's little things you can do to kind of give yourself a little bit better vision. But it all depends on what's going on and what's happening with your eyes.
Okay, I apologize for that. My Wi-Fi did cut out, so I had Aya take over, but there's one last question.
Sure.
Are there any complications when shunting, like occlusions, and do you need to administer an anticoagulant like heparin when you do shunt patients?
Shunting, I'm assuming you're talking about glaucoma surgery. Is that what the question? So when we do shunts, to kind of explain, so when we talk about shunts in ophthalmology, generally we talk about you know, glaucoma shuts that we put in the eye, tubes that we put in the eye, you know, or a tube that we put in the eye to help drain the eye, you know, to help kind of redirect the flow so that there, you know, the eye can lower pressure. What I was talking about earlier with the stents that you put through the lacrimal system, and when we do those surgeries, for example, when we did a dacrocystorhinostomy, or rhinostomy, where we drill through the bone and then we kind of help kind of create a passage between the eye and the nose. Yeah, we ask people to stop anticoagulation, you know, like, you know, those kinds of medications, because bleeding in those types of surgeries can obstruct your vision. And, you know, if you're in a surgery and it's just bleeding everywhere, that's not the best situation.
Awesome. Thank you so much for the incredible and insightful session, Dr. Kanyinda. I really enjoyed how interactive and encouraging you were, and I hope to have a session with you again in the future. If you want to post any of your social media handles or links to your business endeavors in the chat, please feel free to do so. To our Wayne State University students, please make sure you complete the Google survey posted in our Zoom chat summarizing the session to obtain your shadow hours. And thank you all, and I hope you have a great night.